in from the mobile application so that I can keep track of your questions. Okay, so to discuss the physiology of the extraocular muscles, we will pass through different stages. We need to know, first of all, what are the extraocular muscles and what are the functions or the actions of each extraocular muscle, and how do these extraocular muscles work together. So what are the rules that govern the movement of the extraocular muscles, either they causing these extraocular muscles to move together or move against each other, and finally we will highlight the rule of the supranuclear control over the extraocular muscles. So let's begin. As we know from the anatomy, we have 6 extraocular muscles. We have 4 recti and 2 obliques. The 4 recti are the superior rectus, the inferior rectus, the medial rectus, and the lateral rectus, while the obliques are the superior oblique and inferior oblique. The basic kinematics or the basic movements of the eye can be considered in or can be classified into 9 movements. All are initiated from single movement to call the primary position. So we have one primary position and the other 8 positions. So what is the primary position? We will know now. But to just start with, the primary position is the initial position from which all ocular movements are initiated. So we have one primary, and the other movements are 4 secondary movements and 4 tertiary movements. So these are the 9 cardinal gaze or 9 movements of the eye. This is called the primary position. And there are 4 secondary movements and 4 tertiary movements. So what is starting with the first, what is the primary gaze or what is the primary position? The primary position is a position of both eyes, so it is a binocular condition. We cannot judge a primary position by a single eye only. So it is a binocular condition in which the eyes are looking at the infinity, or the target is present at the infinity, and this condition, there is a sagittal plane, which is number 2. This sagittal plane of the head will intersect with the horizontal plane, which is number 4, passing through the center of rotation of the eye, which is here. So if the eye is, we are looking binocularly to a target at the infinity, while the eyes are maintaining a position in which the sagittal plane will intersect with the horizontal plane at the center of rotation, then this is called the primary position of gaze. Hello, can you see my the presentation and hear my voice? So, Dr. Duha and Dr. Rasha, you have a problem at your devices, since other candidates can see the lecture. Okay, then from the primary gaze, we have other secondary gazes. The secondary gazes are either the eye is looking upward, and in this case it's called the supraversion, or the eye looks downward, so it's called infraversion, or both eyes look to the right, then it's called dextroversion, or both eyes looking to the left, then this is called the levoversion. So the thing that's common here that is called version. So version mean it is a conjugate eye movements. Both eyes are moving together. So version again is movement of both eyes together. On the other hand, there is tertiary movements. Then these tertiary movements are a combination of vertical and horizontal element. So the eye can look to up and right or dextro elevation, up and left, which is called dextro or levo elevation, down to the right, which is called the dextro depression, and dextro and depression. So it's called dextro depression. It is down and right, or down and left, which is called the levo depression. Again, the tertiary movements are just a combination of horizontal and vertical elements, either up to the right, up to the left, down to the right, and down to the left. We mentioned something about center of rotation while we were discussing the anatomy of the extraocular muscles. So we said that the movement of the eye are based on three principles or three planes or three axes. They are called the fixed axes. The fixed axes are three axes, one anteroposterior, it is called the y-axis. Another one from medial to lateral, it is called the x-axis. And finally, there is a vertical one from up to downward. It is called the z-axis. So again, the x-axis is from nasal to temporal or medial to lateral. The y-axis is from anterior to posterior, and the z-axis from superior to inferior. And just to remind you with the basic movement across these axes, we've mentioned that along the vertical axis or the z-axis, the eye can move medial and lateral or nasal and temporal. Along the x-axis or the horizontal one, the eye can move upward and downward or elevation and depression. Along the y-axis, or which is the anteroposterior, the eye can either rotate inward or outward, which is intorsion or extorsion. Let's know some information about the center of rotation. The center of rotation is located about 13.5 millimeter behind the apex of the cornea. But this location is not fixed, because if the eye is more myope or more larger, then the center of rotation will be a more posterior. And if the eye is smaller or more hypermetrope, then the center of rotation would be more anterior. The x and z planes are lying in the same plane, or there is a plane called the listing plane. So this grayish square is called the listing plane, which is a plane passing through the center of rotation and contain the x and z axes. This is called the listing plane. So this is just some information about the center of rotation and listing plane that they may be asked in the MCQ exam. So these are the summary of the different axes, and here is this is 8, which is the listing plane. So this was a rapid introduction about the anatomy of the extraocular muscles. I think that what have been mentioned, we all know it because it was discussed before in the anatomy. So let's know now what are the physiology. What are the ocular movements around the axis of fix? We have three basic ocular movements. One of them is uniocular, which is called the duction. And the other two are binocular, which are called the version and the vergence. So what are the differences? Duction, it is just a monoocular movement in certain direction. So whether the eye moves to the right or to the left, up or down, whatever is the movement of the eye, then this is called adduction, or single eye movement to a certain direction. The version, as we just mentioned, it is a binocular movement. In such condition, there is a simultaneous conjugate movements in the same direction. So both eyes move to the right, both eyes eyes move to the left. Both eyes elevate, both eyes depress. Finally, the vergence by C, it is again a binocular movement. It is a simultaneous, but it is non-conjugate. Here is the difference. It is non-conjugate movement in the opposite direction, like convergence or divergence. So both eyes look to the opposite. So starting by the duction. So duction is a movement of one eye. So we just close one eye and test the duction of the other eye. There are different gazes, like for example, adduction, which means that the eye looks medially, or abduction, in which the single eye moves laterally. Supraduction, in which the eye elevates, infraduction, in which the eye depresses, or intorsion or encyclotorsion, in which the eye rotates around the anteroposterior axis toward the inside or the inward. Excyclotorsion, in which the eye again rotates across the anteroposterior axis outward. So these are the 6 movements of ductions. Then we have the version, which is binocular, conjugate simultaneous movement of both eyes toward the same direction. So according to the directions, we have 9 cardinal gaze, or we have 9 versions. This is the primary position that we have mentioned about. If both eyes elevate together, then this is called elevation. If both eyes depress together, then this is depression. So this is elevation and depression. If both eyes looks to up and the right, then this is called dextro elevation. Both eyes looks down to the right, this is called dextro depression. Both eyes looks up and the left, it is called levo elevation. Both eyes looks down to the left, it is levo depression. Both eyes looks to the right, it is dextroversion. Both eyes looks to the left, it is levoversion. So these are called the version movements. So before we talk about which muscles do which movement, let's know what are the kinds of muscle movements. We have 3 muscle movements. We have what is called primary movement, and secondary movement, and finally the tertiary movements. So what are the difference between these movements? The primary movement meaning it is the main action of the muscle. So it is the most powerful action when the muscle is contracting. The secondary action, it is a second direction of movement when the muscle contracts. So it is not the main action and not the most important. So this is called the secondary action. The tertiary will be the least powerful or the least important muscle action, in which as a result of contraction of the muscle. So we said we have different extraocular muscles. We have the medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique, and the inferior oblique. So what are the primary action, the secondary action, and tertiary action of each one of them? The horizontal recti, which are the medial rectus and lateral rectus, have only primary action, because the horizontal recti muscle are purely horizontal movers. They move the eye or is only in the horizontal direction across or around the axis of Z, which is the vertical axis, so that they have only primary action. So they move the eye to the right or to the left or medially or laterally. They just move the eye in the horizontal direction. So there is no secondary action and no tertiary action. The issue here about the vertical recti and the obliques, because these are vertical muscles, and the vertical muscles have a direction of pull that is mostly vertical as the primary action. So they will cause elevation, depression, can cause intorsion or extorsion. But the thing here about the vertical recti and the obliques, that they have there is a direction of pull from origin to insertion, as there is an angle of the muscle to the center of rotation. For example, as I will show you here is the zero axis, and the superior rectus and the inferior rectus make an angle of 20-30 degree with the center of rotation, while the superior oblique and inferior oblique makes an angle of 51 degree. And that's why the vertical muscles, when they contract, they not only cause a vertical movement, but they cause also a secondary action and tertiary action. So what is the primary action of the superior rectus cause elevation, while the inferior rectus cause depression, as it is as they are named. So the recti cause the same action of their names. The superior cause elevation, the inferior cause depression, while the obliques cause an action which is different from their names. So the superior muscle will cause depression, while the inferior muscle will cause elevation. Now we come to the secondary tertiary actions. So just to summarize, the superior muscles are causing intorsion. So the superior rectus cause intorsion, the superior oblique will cause intorsion. The inferior muscles will cause extorsion. So inferior rectus will cause extorsion, inferior oblique will cause extorsions. The recti are adductors. So the superior rectus causing adduction, the inferior rectus will cause adduction. The obliques are abductors. So the superior oblique will cause abduction and the inferior oblique will cause abduction. So this shouldn't be confused with another thing. The action of the muscle shouldn't be confused, especially for the superior and inferior recti and superior and the inferior oblique shouldn't be confused with the direction of maximum action. Meaning that when the eye is looking laterally, it will be just by the effect of lateral rectus. When the eye is looking medially, the eye will be will be withdrawn medially by the action of medial rectus. Both the inferior oblique and the superior rectus are elevators, while both inferior rectus and superior oblique will be depressors. So both of these muscles will pull the eye upward, and both of these muscles will pull the eye downward. The action of maximum action, or if the eye is abducted, or if the eye is drawn laterally and elevate, then this will be the maximum action of the superior rectus. So the superior rectus will be the only elevator of the eye. So don't confuse that it will cause adduction, but it is acting in the abduction, because at the abduction, the superior rectus is the only elevator of the eye. Likewise, the inferior rectus will be the only depressor of the eye in the abduction. While if the eye is adducted, then the inferior oblique will be the only elevator of the eye, while the superior oblique will be the only depressor of the eye. So when we are testing the recti, let me see here. Yes. So again, the medial rectus will cause adduction and the lateral rectus will cause abduction. Superior rectus and the inferior rectus or inferior oblique will cause elevation, while the superior oblique and the inferior rectus will cause depression. And this will and the when we tested the inferior rectus, so the superiors are causing, or the obliques are abductors. So the superior oblique and the inferior oblique are abductors, and the inferior rectus and superior rectus are adductors. But when we are testing them, we are testing in when the eye is looking laterally, then the inferior oblique will be the only elevator, and the superior oblique will be the only depressor. Laterally or temporally, the superior rectus will be the only elevator, and the inferior rectus will be the only depressor. So I hope that this concept is clear to you and not confusing. Now let's talk about the laws of ocular motility. So what are the laws that will govern the ocular muscles motility? First of all, we have the agonist. Agonist meaning that it is any extraocular muscle producing any specific ocular movement. Like for example, if the eye is looking to the right, then this can be due to the action of the left or the right medial or right lateral rectus causing movement of the right eye to the right. So again, this is called the agonist. It is only the movement of one eye to a specific movement. Synergist meaning that they are muscles of the same eye that moves the eye in the same direction. So let's see an example. If the right eye is looking down, then the right inferior rectus and the right superior oblique are called synergist. They are both moving the right eye downward. If the left eye is looking up, then the left inferior oblique and the left superior rectus can be called synergists because they are both in the same eye and both moving the eye to the same direction. So again, synergists are muscles in the same eye that moves the eye in the same direction. Conversely, the antagonists are pair of muscles again in the same eyes that move the eye in the opposite directions. So for example, the right lateral rectus will allow the right eye to move to the right, while the right medial rectus, when it contracts, it will move the right eye to the left. So the right medial rectus and right lateral rectus are called antagonists. Likewise, in the left eye, the left superior rectus will be the only elevator of the left eye in the left gaze. So while the left eye is abducted, it will elevate by the left superior rectus. Conversely, the left superior oblique will be only depressor in adduction, so that both the left superior rectus and left superior oblique are called antagonist muscles. Then we have a term that is called the yoke muscles. Yoke muscles is a term expressing the contralateral synergists, meaning that they are pairs of muscles in both eyes, one in each eye, that produce a conjugate ocular movements. So they are muscles, each one at the eye, so they are in both eyes that when contracting together, they will produce the same movement. Meaning that when the right medial rectus contract and the left lateral rectus contract, it will move both eyes to the left. When the right inferior oblique and the left superior rectus will contract, it will produce levoversion, or it will be the elevation in the left, or a movement of the eye up and left. While in the other hand, when the inferior rectus contract and the left superior rectus contract, they will both draw both eyes into down and right. So again, the right inferior rectus, when it contracts with the left superior oblique, they will cause both eyes to be moving down and right. So these pairs are called yoke muscles. These pairs are called yoke muscles. So we have pairs. These pairs are either in the same eye or separate eyes. Pairs in the same eyes are agonist-antagonist. So the medial and lateral rectus in the same eye are agonist-antagonist. One will cause movement of the eye nasally, and the other will cause movement of the eye temporally. Superior rectus and the inferior rectus, again, they are agonist-antagonist. Superior oblique and the inferior oblique are agonist-antagonist. And we have pair agonists, or what's called the yoke muscles. The yoke muscles are the left medial rectus and right lateral rectus. Here we can see. These are called yoke muscles. And again, the right medial rectus and left lateral rectus. These are yoke muscles. The left superior rectus and the right inferior oblique, and the left inferior rectus and right superior oblique, left superior oblique and right inferior rectus, and left inferior oblique and right superior rectus. It is not uncommon in the exam to be giving you, or that the examiner will give you a pair of muscles and ask you whether these muscles are agonist antagonist, or they are agonists, or they are, what are the relation between these muscles. So you should know what are the basic kinematics or basic movements of the extraocular muscle and the movement of each extraocular muscle alone. and what is the relation between the both eyes, or what are the muscles that will work together. Either they will be synergistic to each other or they will antagonize each other. Now, after understanding the previous terms, we need to understand two important laws. The first law is called the hearing law of equal innervation. This is one of the most important laws in ophthalmology, governing the movement of extraocular muscle. This law states that there is an equal and simultaneous innervation from the brain to the pair of yoke muscles, which contract simultaneously. So, for example, if both eyes here would like to look to the left, so this is the right eye and the left eye. If we want to both eyes to move to the left, then there should be contraction of the right medial rectus and contraction of the left lateral rectus. And if this is movement to the left, then if this is movement to the left, then this should be the contraction of the right lateral rectus and left medial rectus. So let's not just to confuse, let's say that this is movement to the left, and that's why the here is the right medial rectus and left lateral rectus are contracting in order to move both eyes to the left. So the same innervation come to the right medial rectus and to the left lateral rectus simultaneously. The brain innervate both muscles by the same amount so that they will contract to the same by the same amount to move both eyes to the same direction. And this applies to all normal eye movements. The other law, it is called the Sherrington law of reciprocal innervation. The Sherrington law states that there is increased innervation to a contracting agonist muscle. It must be accompanied by inhibition of its antagonist. So here is the agonist and here is the antagonist. If this muscle is contracting, or this is, let's say that this is the lateral rectus, and then this is the medial rectus. So in order for the lateral rectus to contract to bring this eye to this direction, then the medial rectus of the same eye should be inhibited or should receive some inhibition. You can see that this is the increasing innervation to the lateral rectus, but there is inhibition to the medial rectus, because if both eyes or the agonist antagonists are contracting together, they will not produce the action or the desired action. So in order for the lateral rectus to contract, the medial rectus should be relaxed. If the superior rectus should contract, the inferior rectus should relax. So this is called reciprocal inhibition of the antagonist. So let's take this example. If this woman is looking to the left, then she is stimulating her right medial rectus and left lateral rectus. So the medial rectus, the right medial rectus, and the left lateral rectus are called yoke muscles. So hearing law states that for yoke muscles there is equal innervation, bilateral equal innervation to the synergists of both eyes, or to the eyes or to the yoke muscles that will receive equal innervation so that they can move the eye in the same direction. On the other hand, for the left eye, in order for the lateral rectus to contract, the medial rectus should be inhibited. And for the right eye, in order to contract, the medial rectus to contract, the left rectus should be inhibited. This is called the Sherrington law of the reciprocal innervation, which states that the antagonist of each agonist in the ipsilateral eye should receive inhibition or reciprocal inhibition in order for the muscle to or for the eye to move in a certain direction. So is everything clear up till now? Okay, so let's now move to the other topic of the extraocular muscle physiology, which is the supranuclear control. So the eye movement, in order to be initiated, they should have a control from the higher centers. That's what's called the oculomotor system. So in the eye and the motor system are coordinated together via the supranuclear control, which begins by the supranuclear from the brain till the internuclear between the nuclei together, and the brainstem nuclei finally to the infranuclear at the level of the ocular cranial nerves and the extraocular muscles. So in order for any ocular movement to be initiated, there should be a supranuclear center at the level of the brain which will initiate the movement or send the orders to the nuclei of the brainstem, which then can connect together by internuclear connection through specific bundles like medial longitudinal fasciculus, so that they will generate the required stimulation for the specific ocular specific cranial nerves that then will fire the nerve impulse, which will pass through the ocular cranial nerves to finally supply the extraocular muscles that will move the eye in a certain direction based on the program which was ordered from the supranuclear center. So now we are going to talk what is the supranuclear control of the extraocular muscles. So the nuclei of the that will control the extraocular muscles and the muscles itself have been discussed in the anatomy, or this is not the area when we discuss the ocular cranial nerves like the third and fourth and sixth and the extraocular muscles. So you already know this, but now we need to know what are the supranuclear control and what are the different types of extraocular movements. Basically, we have two main movements. So we will skip the duction, but we need to know what are the versions and the version and the versions. As we said, they have the same direction, and the versions will be just binocular conjugate eye movement or non-conjugate eye movement to opposite directions. And these are the movements which have supranuclear control. So basically, to let you understand, the supranuclear control, meaning that what if we are looking by my right eye to a certain direction, like let's say to the right, and by my left eye also to the right, so both eyes moving to the right, which center or which facility that will facilitate connection of both eyes? Which center that will give the same orders to the right eye and to the left eye in order to move together? That's why this is valid for the binocular eye movement like version and vergence, because we need some sort of connection between both eyes. So this connection will be at the level of at a higher level at the visual at the cortex, or at the supranuclear level, or even nuclear level. So the eye movements can be classified into, as we said, version and vergence. So for the version, we have different kinds like the saccadic eye movement, the smooth pursuit eye movement, the optokinetic movement, which is initiated by an optokinetic drum, as we mentioned in the physiology of the visual acuity, vestibulo-ocular, which is initiated by the vestibular system. So these are called version, in which both eyes move together to the same direction. And also we have vergence, in which there is convergence, and divergence, in which both eyes move in opposite directions. These movements can also further classified not according to if it is conjugate or disconjugate, but to its purpose. So some movements can be some movements are causing a gaze shift, while other movements cause gaze maintenance. For the gaze shift, we have the saccades and the smooth pursuit and vergence. And this is simply just we want to locate a certain object, or we want to move our eyes to a certain objects. Either this movement we want to place this object in the fovea, then this is called saccades. After the placing of an object at the fovea by the saccades, if we want to track this object, if it is moving, then this is called the smooth pursuit. If an object is moving close to the eye and we want to look or gaze shift to this object, then this will be called convergence. If the move of the target is moving away from the eye and we want to look at it, then this will be a divergence. Other classification according to the function are called gaze maintenance. So they maintain the gaze, like the optokinetic nystagmus. You remember when the examiner was holding the optokinetic drum and rotating it in front of the child's eye, the child's eye are moving with the rotation of the drum. So it will maintain its position on the alternating dark and white stripes. Also, the vestibular movement is one kind of movement that will be supposed to maintain the gaze during brief head rotation. And finally, a fixation can be considered one of the gaze maintenance as we hold both eyes conjugately on a particular position. So let's now discuss these movements in more details. The saccadic movements, what is meant by the saccadic eye movement? Saccadic eye movement, it is a rapid eye movement. It is very rapid conjugate movement. So both eyes will move together in the same direction that have a certain purpose. This purpose is to place an object of interest on the fovea. So, for example, if I'm presenting to you this lady face, so what happens when you are looking to this lady's face? Let me tell you something. If I place an electrode over your both eyes and record their movement, their movement will be like this. So, for example, you are moving toward her eye, then her right eye, then her left eye, then again back to her right eye, then back to the left eye, then her nose, then her mouth, then her hair. So you are moving your eyes at fast movements and circulating your eyes fast movements in order to place an object of interest on the fovea, on your fovea. So these movements, these rapid movements, it is called the saccadic eye movement. Again, if I'm placing to you this paragraph and you are reading it, actually what you do is saccadic eye movement. So you saccade your eyes from one word to the other in rapid eye movement. Then after the end of line, you saccade your eyes in order to place the first word at your fovea, and then again move from word to word, then returning back to the first word, and etc. So these are called the saccadic eye movement. Now you understand what is the purpose. It is just to place an object in the fovea. That's why it is very rapid. So the stimulus of interest will be an object in the peripheral field. So if there is an object, like for example, if like a bird in your peripheral field, and you want to look at it suddenly, then you will move your both eyes toward this bird, and this is called the saccadic eye movement. We have two types: the voluntarily, so that you voluntarily move your eyes toward the object of interest, or it can be involuntarily. Involuntarily, like sensory evoked. So you for example, if I place to you this smiley face and you suddenly look at it, this was presenting this smiley face in front of you. But since I presented it, you involuntarily move, your eyes are moved directly toward it, so that you have now performed a saccadic eye movement. Also, if you hear, for example, an explosion, so you involuntarily moving your eyes to see the source of this explosion, this is an auditory stimulus that will elicit a saccadic eye movement. Nystagmus has a fast phase and slow phase. The fast phase of nystagmus is considered a saccadic eye movement. Also, it can be pathological or induced, and also such movement and the optokinetic movement or optokinetic nystagmus. This can be also considered some kinds of pursuit eye movements, or the nature of movement. The purpose of movement is vestibular or optokinetic, but the nature of movement, what are its character, what is its velocity, then it is a type of saccadic eye movement. So what are the characters? Latency from the time that the center of the brain initiate the movement till the actual execution of the movement is about 200 milliseconds. So this is called the latency. As we mentioned latency in the electrophysiology yesterday, it is just the time that elapses between the order and the actual execution of the movement. This movement, or the saccadic eye movement, is of high velocity. It's about 100 to 700 degrees per second, so that you can move your eyes very rapidly in order to place the object of interest at the fovea, and that's why it also required some alertness. There is some unique features regarding the saccadic eye movements that once it is initiated, you cannot stop it or you cannot modify it, as it is called a pre-programmed movement. So for example, if I'm placing to you this photo and ask you to look from A to B, and then you so that if you are now looking at A and or at point A, then I ask you to look at point B. You can't stop in the middle. But you may ask or you may wonder, but I can. So when you are asking me to move or to if I'm looking at A and you ask me to saccade to point B, and I can stop in the middle. But let me tell you something. If you stop in the middle, then your intention from the start that you are not going to look to B, but you are going to look to the cross. So that's why it is called a pre-programmed. Once if you are intending in the first place to look from A to B, you cannot stop in the middle. But if you stop in the middle, then your intention from the start is not to perform this full saccadic eye movement. So it is once initiated, it is a very rapid and it cannot be stopped or modified as it has a pre-program. Also, there is a character called the saccadic omission or saccadic suppression. So when you are saccade from the point A to point B, when you are moving your eye from A to B, you will not notice that there is a blurry vision in between. So this arrow will not appear to be blurry. If you want to experience this, try to use a camera that doesn't have any image stabilizer, and not move and take and hold the camera to a certain target and then move it rapidly to another target. Especially if you are recording a video, you will find that the objects in between the two targets are blurry. But this doesn't happen with the eyes because the brain has a function called saccadic omission, so that you cannot find any blurry targets in between. So this is for the sake of better vision. So let's here talk about the pathway. Where does the saccadic, or what is the source of the saccadic eye movement? The saccadic eye movement is initiated from the frontal eye field, or what's called area number 8, which is present in the contralateral premotor cortex. This is very important. So if you wanted to look at the target at the right, then the impulse is initiated from the left frontal eye field. And vice versa, if you want to look at a target present at the left, this you should be or must be initiated from the right frontal eye field. Then impulses pass from the frontal eye field to descend in the fronto-mesencephalic pathway through the anterior limb of the internal capsule, as it wants now to innervate the higher centers present in the brainstem. So it moves it decussates in the lower midbrain at the level of inferior colliculus to terminate into two stations. First one is called the horizontal gaze center, or the other name parapontine reticular formation, or PPRF, which is present in the pons. So this will be concerned with the horizontal eye movements, and it will receive stimulation from the contralateral frontal lobe. So for example, if you are looking to the right, so your right horizontal gaze is stimulated, but your left frontal field is stimulated. So the left frontal field will stimulate the right horizontal gaze in order for both eyes to move to the right. So what do you expect when one of the final destinations of this pathway is to stimulate the horizontal gaze center? So I guess you think now that the other pathway is to stimulate the vertical gaze center. So the vertical gaze center, it is called the rostral interstitial medial longitudinal fasciculus, or sometimes they call it the interstitial nucleus of Cajal. This nucleus will now receives equal stimulation from both frontal lobes because they will ascend and descend in the medial longitudinal fasciculus to supply the vertical recti and the vertical oblique muscles. So they will supply the vertical muscles, and they will be present at different levels. So they will elevate or the impulses will ascend and descend in order to stimulate these muscles. So again, let's summarize. If you the centers or the pathway for the saccadic eye movement, it is initiated from the frontal eye field or area number 8 in the premotor cortex or the frontal eye field. Then impulses will pass into the opposite side until they reach the level of the inferior colliculus or at the midbrain. They will supply the two centers. The yellowish one or the first in the pons, it will supply this bluish one will be the horizontal gaze center or parapontine reticular formation, which will connect the third nerve and the sixth nerve in order to initiate the horizontal eye movements. And it will also supply this yellowish one, which is called the rostral interstitial medial longitudinal fasciculus, which will be the vertical gaze center. This vertical gaze center will be concerned with connection of the vertical muscles like the vertical recti and the obliques in order to stimulate vertical eye movement. Here are the gaze centers. So the gaze centers are either the horizontal or parapontine reticular formation, and the vertical, which is called the rostral interstitial medial longitudinal fasciculus. Horizontal will control the horizontal eye movement, which basically are the lateral and the medial recti, control the connection between the lateral and the medial recti, while the vertical is more complex as it will connect the superior and inferior recti and superior and inferior obliques. So the gaze centers are the second station in the supranuclear control of the extraocular muscle. The first center or the first station will be the cortical level or present at the cerebral cortex, like the area number 8 of the frontal eye field. The second station will be the gaze center, which is the horizontal and vertical. And from these centers, the impulses will pass in order to supply the different extraocular muscles or supply different brainstem nuclei. The second movement or the second kind of movement, it is called the pursuit eye movement. Pursuit eye movements meaning that after location of a certain target by the fovea, and if this target is moving, then the eye is tracking this target or pursuing this target by a kind of movement that is called the pursuit eye movement. For example, if this eye is looking to this bird and this bird is now moving from point A to point B, then the eye should look downward so that the location of the when at the first instance when the object was located by the fovea by the saccadic system, now the object or the number A is not locating even when the bird is moving, the object or this bird is not present on the fovea anymore, but it is shifted here. So the pursuit eye movement is a tracking system that is allowing the eye will descend by a similar velocity like the velocity of the original object. So this the movement of the eye will be relative to the movement of the object in order to maintain this object on the fovea. So that this is a tracking system or a pursuit movement, and this is can be will be the function of the pursuit eye movement. So what is the stimulus of the smooth movement? It is just to keep the ocular fixation locked on the target. So once the target is located by the saccadic system, it is maintained the fixation by the pursuit system. Then movement of the image of the target across the foveal and the perifoveal region, meaning that the main stimulus of the pursuit, as it's apparent from its name, to pursue an object is to track the object or to move with the movement of the object. So if the object moves away from the fovea till a certain limit, the eye will make a corrective movement in order to keep maintaining this object on the fovea. Sometimes the pursuit movement cannot or doesn't need a visual stimulus in order to be active. Like for example, for some patients who have some hallucination or visual hallucination, so they are seeing non-existent target, and these targets can be moving. If they are moving their eyes with this target, then they are performing pursuit eye movement, but actually there is no target that they can see. Also, if you close your both eyes and try to track your fingers as you move it in the space, you will be able to do so, despite your inability to see your finger, but you still can move your eyes with the movement of your finger. So that this is also an stimulation of the pursuit system, and this is doesn't need to have a visual stimulus all the time. And this has been asked before in the MCQ. So what are the characters of the pursuit eye movement? Pursuit eye movement are slower than the saccade and much smoother. So saccades mean that you are moving from point to another point. This movement is very rapid, and it is programmed, and so that it's not smooth. So that's why there is saccadic omission. You cannot see the targets in between. But in case of the pursuit, it is sometimes referred as smooth pursuit because your eyes are moving slowly to track the target, and you can see any targets in between. It has a latency of about 125 milliseconds and a velocity of about 30 to 40 seconds. So 30 to 40 degrees per second. So this doesn't have, or that's why it is slower. In contrast to the 100 to 700 degrees per second speed of the saccadic eye movement, this eye movement or the pursuit eye movement has only 30 to 40 degrees per second. So when this bird is moving from direction to another direction, then your eyes are moving slowly in the space in order to keep tracking this bird in the sky. So what happens if the bird movement is too rapid? So it is much more rapid than 30 to 40 degrees per second, and now you are not able to catch this bird by your pursuit movement. So the eyes tend to, or the pursuit movement is having a velocity of 30 to 40 seconds. In some books it says up to 60 seconds or 60 degrees per second. After this, then the bird will fall out of your visual field or out of your central field. Then what happens next is that the eye will perform a saccadic eye movement in order to catch up. Let's say, for example, that the bird is moving from here to here, and you have been able to track the bird as it's present here because the range was about 40 degrees per second. But what happens if the bird is moving faster? So it is now 100 degrees per second. Then the remaining part or the remaining space can be compensated by the saccadic eye system. So there will be a corrective saccadic movement in a cogwheel manner. So this is the cogwheel. So the eye will move in a cogwheel manner in order to catch the missed object that was not that hasn't been catched by the pursuit system. So if the object is lagging behind or the eyes are lagging behind the target, then a corrective saccadic movements are made in a cogwheel manner in order to maintain the gaze on the target of interest. And also it requires some degrees of alertness. The pathway of the saccadic eye, the pursuit eye movement is more complex, and I didn't find that is asked in any exam, but let me tell you also. The center is from the what's called the medial temporal area, and this medial temporal area receives from the visual cortex. So the medial temporal area needs to have some information about what is the target of interest. So this target of interest it's perceived from the visual cortex. So the visual cortex say to the medial temporal area that we had a bird, or we have a bird that is moving, and please keep tracking of this bird. So the medial temporal area send impulses that will pass with the medial superior temporal area and the frontal eye field that will give impulse to pass through the dorsal lateral pontine premotor nucleus, which will be controlling the ipsilateral pursuit. So this will be the center that will control the ipsilateral pursuit with the same eye. So if there is the bird is moving to the right, then it will be projecting from the right dorsal lateral pontine premotor nucleus, causing right pursuit movement to the right. Also, it will send the impulses to the folliculus of the cerebellum and vestibular nuclei in order to organize the pursuit and the head movement. So let's say, for example, that the object of interest is out of your visual field now, and you need to turn your head in order to be able to catch it. So the dorsal lateral pontine premotor nucleus will send the impulses to centers that are concerned with the head position and the equilibrium present in the cerebellum and the vestibular nuclei in order to move your head and the neck muscles. Then the other nucleus that will receive impulses from the medial temporal area is called the nucleus of the optic tract, which will be concerned with the optokinetic nystagmus. So the optokinetic nystagmus has a second phase of smooth pursuit movement. So it has a rapid phase and slow phase, and this slow phase is a pursuit eye movement. So here is the center, the medial temporal area that receives input from the visual cortex to the visual cortex that now see the target by the saccadic eye system, and then it sends impulse to the frontal eye field and the dorsolateral pontine nucleus that will send the impulses to the cerebellum and the vestibular nuclei to see this dorsolateral pontine nucleus will see the ipsilateral pursuit, and it can send impulses to the cerebellum and the vestibular nuclei in order to see the target if it is out of the visual space by controlling the head muscles. And also it will send impulses to the parapontine formation and other centers. So to summarize the saccadic eye movement, this is the pattern of saccadic eye movement. It is very fast movements to locate an object present in the fovea, but so this is not very smooth, while the pursuit eye movement, it is a smooth movement. It is just a slow movement in order to track the object or to maintain the fixation over the object. I hope that they are clear. Then we have another kind of movement which is called the vergence, and in case of vergence, as we said, they are a non-conjugate eye movement. They are synchronous, made at the same time, but the both eyes are moving in opposite direction. So the right eye here is moving to the left, and the left eye here is moving to the right, in order to do convergence and to focus on the tree. So the stimulus here is the presence of blurry image or double image if the tree is very close to the eye, or if we are focusing on the mountain behind, then the picture of the tree will not be in focus. So both eyes converge in order to see the tree is in focus. So here the stimulus is present or some sort of diplopia. As you can see that here the tree is falling on non-corresponding retinal points of both eyes. You remember this from the previous lecture about the binocular vision? We said that there is what's called physiological diplopia. If we are maintaining fixation over the mountain here is in the horopter, and the areas before are falling on non-corresponding retinal point, leading to cross diplopia. so that the image of the tree here or the tree here is seen double. That's why both eyes converge in order to place the tree on corresponding retinal points over both eyes. So the purpose of the convergence is to align the visual axis to maintain the bifoveal fixation. So since the object fall on the both foveas, it is falling now on corresponding retinal point, and the stimulus will be the retinal disparity, as the stimulus will be the presence of an object on non-corresponding retinal points leading to diplopia. It has a latency of about 160 milliseconds and a velocity of about 20 degrees per second. And its center lies in the mesencephalic reticular formation or in the nucleus reticularis tegmenti pons. Then we have an important system which is called the vestibular system. So what is the vestibular system? If you are closing your eyes and you are upside down, you will still be able to know that you are upside down or your head is below and your legs are above, although you are not seeing. And this is because of the vestibular system. The vestibular system is a system that is associated or responsible for maintaining our balance and our orientation in the space. It is mainly made of what is responsible for the balance is not the whole ear, and it is the inner ear, and a specific part of the ear is called the semicircular canals. The semicircular canals have some things called the otoliths. These otoliths are moving within these canals. That's the movement of these otoliths will give us the orientation of space. So there is an important reflex that is commonly asked in the exam. It's called the vestibulo-ocular reflex. So this is considered one of the fastest reflexes in the body, as its latency is only 10 milliseconds. So you can see this is very, very fast. So the eye movement lag behind the head movement by 10 milliseconds. So if you want to test this test on yourself, let's try this test. If I am putting this cross in front of you, and now please fix on this cross, and slowly, while you are fixing on this cross, move your head to the right. Keep your head moving to the right while you are looking to this cross. Now, your head is rotated to the right, and now check where your eyes. You will find that your eyes are not in the primary position anymore, because your right eye is now moving to the right, or your left eye is now moving to the left, and your right eye is now moving to the left. So when the head moves to the right, the eyes move to the left by the vestibulo-ocular reflex. So this reflex is to maintain fixation. When I place this cross in front of you, you want to maintain your fixation. So despite your head movement, you have been able to maintain your fixation by your eyes movement. So what happened here? What happened here is that your right eye was looking to the left, your left eye is looking to the left, so your left eye has lateral rectus contracted, and your right eye is looking to the left as well, so your right medial rectus is contracted. So what makes the right medial rectus and the left lateral rectus contract in order to maintain the gaze at the left? This is what is the vestibulo-ocular reflex about. So let's know what is the pathway of this reflex. So what happened when you moved your head to the right? Let's say here the head is moving to the right. First of all, there is a stimulation of the right semicircular canals in the vestibular system. And this stimulation of the right semicircular canals will cause stimulation of the right vestibular nerve. So the right vestibular nerve is one of the two parts of the vestibulocochlear nerve. which is the eighth cranial nerve, which is concerned about both the hearing and the balance. So the right vestibular ocular or the right vestibular branch of the vestibulo-ocular nerve will pass through from the nucleus vesicularis to pass to the other side parapontine reticular formation. Do you remember the parapontine reticular formation? Yes, this is the horizontal gaze center. So the eye or the pathway is now crossing the other side. So for impulses from the right passing to the left. Now the left parapontine reticular formation is stimulated. So what is the role of the parapontine reticular formation? It will connect the medial and lateral rectus. So it will send the impulses to stimulate the abducent nucleus of the same side. So it will stimulate the left abducent nucleus, causing stimulation of the left abducent nerve, causing stimulation of the left lateral rectus, so that the left eye will move to the left. On the other hand, the parapontine reticular formation will send the impulses that will pass on the other side, passing through the medial longitudinal fasciculus. We will talk about this in a while. The fibers will pass through on the contralateral side through the medial longitudinal fasciculus that will supply the medial the oculomotor nerve nucleus. The oculomotor nerve nucleus, specifically the medial rectus nucleus, will send the impulses passing through the oculomotor nerve to supply the right medial rectus, causing the right eye moving to the left, or adduction of the right eye. So movement of the head to the right, leading to movement of both eyes to the left through the vestibulo-ocular system. Let's repeat this again. Again, by moving the head to the right, this will cause vestibulo or stimulation of the vestibulo-ocular reflex. The afferent pathway will be through the vestibulo-ocular nerve, specifically the vestibular nerve of the vestibulo-ocular nerve, which will be stimulated by movement of the semicircular canals in the vestibular system. The vestibular nerve will send the impulses to pass or to cross the other side in order to relay in the parapontine reticular formation on the other side, so it will stimulate the left parapontine reticular formation. The left parapontine reticular formation is the center for horizontal gaze. So the left parapontine reticular formation causes movement of both eyes to the left, and the right parapontine reticular formation will cause movement of both eyes to the right. Here the left one is stimulated. So it will stimulate the ipsilateral or the same side abducent nucleus, which will send the impulses through the abducent nerve, causing the stimulation of the left lateral rectus, leading to movement of the left eye to the left. And then it will send the impulses to cross again the midline in order to pass through the medial longitudinal fasciculus, which will connect the sixth nerve nucleus to the third nerve nucleus on the other side. The medial longitudinal fasciculus will cause, the impulses will pass through the medial longitudinal fasciculus in order to relay on the third nerve nucleus to stimulate the medial rectus nucleus of the right side. So the oculomotor nerve will supply or stimulate the right medial rectus, causing the right adduction or movement of the right eye to the left. So with the head movement to the right, this will lead to movement of both eyes to the left. Another important reflex, which is again related to the extraocular muscle movement, which is called the oculocardiac reflex. This reflex is of extreme importance, and it is well known to all strabismologists and all anesthesiologists because it will connect both the heart and the eye. So what is the stimulus of this reflex, and what is the response of this reflex? This reflex meaning that there is decrease in the pulse rate or bradycardia in response to traction of extraocular muscles or the globe. The importance of this reflex is that it is very sensitive in neonates and children. That's why this reflex should be monitored by the anesthesiologist during the extraocular muscle surgery. because if the surgeon is doing much traction over the extraocular muscle while recession or resection, and he is not paying much attention about this reflex, then it could lead to bradycardia, arrhythmia, or even asystole. So there could be death of the child due to compression or due to traction of the extraocular muscles. So that's when the anesthesiologist should alarm the surgeon to stop the surgery or to give some measures like intravenous atropine in order to increase the heart rate. So what is the pathway of this reflex? The stimulus will be traction of the extraocular muscle or compression over the globe, and this impulses will pass through the afferent pathway, which is a sensory division or the ophthalmic division of the trigeminal nerve, which now will relay on the sensory nucleus of the trigeminal nerve. So the sensory nucleus will be the center of this pathway or this reflex. Then from the trigeminal nucleus, it will send the impulses to the cardiovascular inhibitory center present in the brainstem, which is the center or the cardiac center present in the brainstem, which is concerned by regulation of the heart rate. This center will stimulate the vagus nerve, as you can see here. So the vagus nerve here is the efferent. So the efferent will pass to the heart, causing inhibition of the cyanoatrial node or the SA node, causing decreasing the heart rate, leading to bradycardia. Let's see another example. If there is compression on the globe, or if there is a traction of the extraocular muscle, then this will lead to an afferent lesion or afferent pathway through the sensory division of the trigeminal nerve that will pass through the trigeminal ganglion and then the sensory nucleus in the brainstem that will then send impulses to the cardiovascular center or that will send impulses to the vagal nucleus, leading to the efferent pathway. This efferent pathway is through the vagus nerve. The vagus nerve will now stimulate the SA node, causing decreasing the heart rate or bradycardia. I hope that this is clear now. Finally, we will talk about the medial longitudinal fasciculus. So this can be also considered related to the higher centers of the brain because it is also related to connection of different nuclei of the extraocular muscles and different brainstem nuclei. So you can consider the medial longitudinal fasciculus like the telephone cables. So the telephone cables are connected in somehow. So if you are like calling someone in another country, you are not calling him directly, or you are not calling his telephone number directly, but you are just calling this the central telephone service, and the central telephone service will connect you to his line until you can reach his number. The same thing occurs with the medial longitudinal fasciculus. So the medial longitudinal fasciculus just to connect different multiple cranial nerve nuclei in order to produce a specific function. So what are these functions? We have just mentioned one of them right now, which is transmission of signals from the vestibular nuclei to the oculomotor nerve. So in the vestibulo-ocular reflex, when there is a stimulation of the vestibular system, then there will be the vestibular system will pass the impulses to the sixth nerve on the same side, or the parapontine reticle formation, which will stimulate the sixth nerve on the same side. But we need also the other eye to move, so it will send the impulse to cross the midline to ascend in the medial longitudinal fasciculus. Here it is the sixth nerve. It will send the impulses to cross the midline on the opposite side in order to connect to the third nerve nucleus, so that both horizontal recti will contract together. So the left lateral rectus and right medial rectus will both contracting together. So again, it will cause transmission of signals from the horizontal gaze center to the opposite medial rectus nucleus. Also, it can transmit signals from the vestibular nuclei to the nucleus innervating the neck muscles. So, for example, the muscles, the accessory nerves that supply the trapezius and the sternomastoid muscles, if you are looking to a target and you are moving, if you want to move your head and the neck, is in order to see this target, then the stimulation of the muscles of head and the neck is coming from the trapezius and steromastoid muscles, which are innervated by the accessory nerve. This accessory nerve is receiving their stimulation or their input from the ocular cranial nerve that move to the eye, so that they are both connected together by the medial longitudinal fasciculus. The important application of the important information about the medial longitudinal fasciculus here is the horizontal gaze or the horizontal eye movement. So let's just remember, or let me remind you about the pathway of the horizontal gaze. So we said that in order for both eyes, like the right eye and the left eye, in order to look at the left, then stimulation comes from the right frontal eye field or area 8 that will send across the brain and the brainstem, and then it will cross the opposite side to stimulate the left parapontine reticular formation or the left horizontal gaze center. The left horizontal gaze center then will stimulate the left abducent nucleus. So this is the left and this is the right. So the left abducent nucleus will stimulate the left lateral rectus, causing the left eye to look to the left. And then the parapontine reticular formation will send the impulses or through the sixth nerve that will cross the other side to ascend into a track. This track is called the right medial longitudinal fasciculus. Till it supply the right oculomotor nerve, the right oculomotor nucleus will give impulse through the oculomotor nerve to supply the right medial rectus, causing the right eye to look to the left. So, in order for a person to look at the left or for the left gaze, this is the primary gaze, and since this pathway is intact, then the person can look at the left. If the pathway on the other side, starting from the left frontal eye field to the right horizontal gaze center, to the right sixth nerve nucleus, to the left MLF, to the left medial, to the left oculomotor nucleus, if all this pathway on the other side is intact, then the person will be able to look to the right. So there will be no problem on the right gaze and no problem on the left gaze. So what happens if there is a lesion in the medial longitudinal fasciculus? If there is a lesion in the medial longitudinal fasciculus, there will be a syndrome called the internuclear ophthalmoplegia. Let's say, for example, if the patient has a right medial longitudinal fasciculus lesion, in the primary gaze, the patient will have straight eyes because this affection will cause deviation or lesion of the eyes while they are moving in a certain gaze, not in the primary position. If the lesion is in the right MLF, the right gaze will be normal because the right MLF will be involved in the left gaze, not in the right gaze. Then in the left gaze, there will be defective right adduction and ataxic nystagmus of the left eye. And the convergence will be intact if the lesion is discrete. Let's see this in action. Let's say, for example, here is a patient, here is a brainstem, and the lesion is present at the right medial longitudinal fasciculus, and we ask the patient to look to the left. What will happen? If the lesion is present at the right MLF, let's see what happens when we ask the patient to look at the left. Then the input is coming from the contralateral frontal eye field or the right frontal eye field that will supply the left or cross the other side in order to supply the left parapontine reticular formation. Then it will supply the left abducent nucleus. Then it will send the impulses to pass on the other side or the contralateral medial longitudinal fasciculus in order to supply the right oculomotor nucleus. So what happens in the primary position? If the patient's primary position, there will be normal because there is no this or lesion in the medial longitudinal fasciculus will affect the gaze or the side gaze, not the primary position. If you ask the patient to look to the right, the patient will be able to look to the right normally. So the right eye will abduct and the left eye will adduct normally, because right MLF or right medial longitudinal fasciculus is involved in the left gaze, not in the right gaze. When we ask the patient to look to the left, what happens now? What happens now is that the right third nucleus doesn't receive any stimulation or doesn't receive any input due to lesion of the right MLF. This leads to that the right eye is unable to adduct. And the left eye will be able to abduct because it will receive stimulation from parapontinal reticle formation, but this stimulation will cause ataxic nystagmus. So although the left eye is abducting, there will be ataxic nystagmus or nystagmus of the left eye. And in order to differentiate that there is no lesion in the medial rectus, then if we ask the patient to cross his eyes, he will be able to cross his eyes normally. That's meaning that the medial rectus and the third nerve itself is functioning well. But the lesion here in the higher center, because if we are using a higher center other than the medial longitudinal fasciculus, the eye was able to adduct. So the convergence use another center and another pathway other than the MLF, so that the eyes are able to adduct. But when they are asking the patient to look to the left, and we are now utilizing the right medial longitudinal fasciculus, the right eye was not able to adduct. So I hope that this is clear. Do you have any question? Any questions in the physiology of the extraocular muscles?